So we have this elderly female, and we see incidentally something in the groin area. Let's see it on axial. Any idea what is going on? I can change the window on axial and that might help.
Are you talking about this foreign body, external?
Yes.
Oh,
I was like, I'm looking at the groin, I don't see anything.
some kind of serrated, oh, catheter? Wait, and it's tubing. Is it some kind of Foley?
Like a
that's
radiation.
external?
Oh, I mean, I don't know. It's
Drain or Foley?
Yeah, kind of Foley. It is a PureWick catheter, and it is for urinary incontinent patients, and
Free due to falls and a lack of user dignity. The PureWick system is an innovative option to managing urinary incontinence at home. The PureWick female external catheter is simple and non-invasive. The female external catheter works outside the body to draw urine away effectively into a sealed container. The PureWick system makes better sleep possible.
So you still have to be connected to that device. You can't like walk around with this thing.
yes,
Okay. But it's for like incontinence overnight.
yes.
Got it. Interesting. And apparently for when you're getting a CT scan.
Yes.
Cool. I can see that being more comfortable and maybe leading to less infections than an internal catheter, like long-standing.
Absolutely.
This was a nice catch by my fellow. And the finding is on these images, just like these 5 images.
Bilateral symmetric masses below the latissimus dorsi.
Yes. So what do you think they are?
Elastofibroma.
Yeah.
Yeah, exactly. So Elastofibroma dorsi, which I just, hadn't seen in a long time, but these are basically benign proliferation of like fibrous masses. They're often unilateral, but can be bilateral. They're usually in older women. They can cause pain, and they can also cause like snapping and clicking when you move your scapula. They tend to be just below the scapula, and they can be incidental. So in this case, the patient actually wasn't having symptoms, but incidentally, we saw these bilateral fibrous masses. Good job. Okay.
Also, at times, they may not be as bulbous as they are seen. They may be very tiny or almost not seen. So PET CT picks them up, and that's a better modality to pick them up.
Oh, nice. So if the patient's like symptomatic and you're looking for them.
I mean, the scan is done for something else, and when we see bilateral symmetric uptake, and then we ascribe it to, because we do not see a mass, we see just uptake, so we ascribe it to elastofibroma rather than just masses.
Got it. I would have said like maybe brown fat or something if I'm not seeing anything on the CT, but okay, that makes sense. Like it's like an earlier part of the process.
Yes.
Who has had a suspension, sacrospinous ligament suspension, which was complicated. All of this was done elsewhere. And so they presented to us because kind of removal, and because it was previously attempted to remove it multiple times prior to coming to see us, and they weren't able to remove it. So this is a great MR anatomy of the sacrospinous ligament suspension. So here's a sacrospinous ligament right here. Right there, sacrospinous ligament. And then this is a suspension material right there that goes to the vagina So here is the post-con, and it's dramatic on the post-con because there's probably superimposed inflammation and maybe infection. So there it is, sacrospinous ligament suspension material right
Would
there.
that be called the same thing as a colpopexy?
No.
That goes to the coccyx, right?
Yeah. No, that's like a hanging thing.
Yeah, that comes down here.
Got it. Okay. And then this one
is more
here
lateral.
goes to the laterally to the ligament.
Yes. Yeah. Yep, exactly. So, and then there's probably there's a developing fistula or something, with the vaginal canal up here by the apex. So pretty complex case. And here's the coronal view of that. And then you can see that material that they wrapped around the sacrospinous ligament to suspend the vagina.
Cool. And you didn't give gel, right?
We may have given a little bit of gel, or maybe that's just I don't remember. Yeah, we usually do give gel though. Yeah.
So,
but
like,
here
how
it's
can
not
you
really
tell
good
then if
extension.
I guess it shouldn't be communicating with the vaginal lumen. So if that fluid in there could be the gel, but either way, that's a fistula.
Oh yeah, I see what you're asking. So I like to me, like I almost see like a defect. I didn't read the study, but like, let me see, where was it? Was it here? Like it almost, sometimes like if there's a mucosal disruption or whatever, like you can see it. And so that's what I thought I saw.
Yeah, that's what I'm thinking too. But I'm also thinking like that could exaggerate this fluid-filled channel if you're putting gel in.
Oh yeah, there's not a lot of distension, so I don't remember if gel is given. This was a case that was shared with me by Maria. But yeah, sorry, I don't see a lot of gel in vagina, so maybe not. But there's some in the external, like introitus area, so I thought maybe there was. But I think when we do give gel, there's a lot more distension of the vaginal canal than what I see here.
Yeah. Cool.
So I don't remember the history of this patient, but the scan was done for definitely a cancer worker, and then a little bit of hyperintensity, a little bit of uptake was taken up nearly symmetrically, and then this was ascribed to Elastofibroma dorsi.
Yeah, this is a great example of what you were saying. Like you don't really see anything there, especially this person is very skinny.
And I can also show what I just found. So on imaging, it presents as poorly defined soft tissue masses with CT attenuation closely resembling skeletal muscle. And they are hot on PET CT, but symmetry can help us differentiate. That's about it.
Nice, thank you.
Thank you.
A patient, I'm sort of withholding the history. Yes, the most striking appearances on MR, on the post-contrast. You can see the entire liver is filled with these avidly enhancing lesions. When we look at concomitant T2, right, not a lot of signal. Maybe here and there, there's a little bit of signal. Maybe there's like central, almost like a scar in this lesion. Some diffusion restriction in some lesions, but not all of them. And this is the pre and post. You can see that this is a pre. Again, the liver is just filled with these odd-looking, relatively T1 hyper-intense areas, right? And these areas, this is the delay to kind of retain contrast So any kind of thoughts about what we're dealing with? I'll bring up here for your viewing pleasure. Young
I
women.
was
Oh man, I don't actually remember
ileosis.
young men or women.
I
Okay,
was
so it's a
also
great
thinking-
thought, right? So it's something, yeah.
Yeah, I was also thinking ileosis because they're so blobby looking.
Mm-hmm.
How about NRH, nodular regenerative hyperplasia?
I'm sorry?
Nodular regenerative hyperplasia.
Kind of like he's saying the FNH spectrum.
Yeah. So, you know, for they're not going to be great for what do you call it, for NRH, because that looks more like, it almost mimics cirrhosis, and it kind of looks nodular. This one has like some sort of vascular process, right? It just looks at vascular. So anyways, this is a patient with hereditary telangiectasia. So these are all telangiectasias, and she has so many of them that she actually has high output heart failure, and she's listed for heart transplant.
Wow.
Wow. They often get like a really hypertrophied hepatic artery, which kind of looks, it definitely looks a little hypertrophied. And those larger lesions, are those FNH? What are those larger ones with like central scar?
I think some of them are FNHs. Unfortunately, we don't have any studies done with EVIS, but I imagine some of these are FNHs because there's so much vascular abnormality in this case, and FNHs tend to happen. So I think it's probably a combination of FNHs and telangiectasia. My guess, and I have no way to substantiate that guess, is that the things that have a little bit diffusion restriction are actual FNHs.
Yeah.
But I can't prove that.
Yeah, they look different than the rest. Wow, good case.
Right. Fun, right?
This is the patient whose status was liver transplant. So most of our transplants are deceased cardiac death, DCD. And for post-op evaluation, we include MRCP as part of the routine post-DCD transplant evaluation to look at specifically biliary ducts. So we to assess for ischemic cholangiopathy and also biliary anastomosis. So we use pumps now. So whenever we harvest the donor organ, there's a pump that basically flows oxygenated blood through this liver while it's being transported. It's pretty cool. There's a YouTube video on that if you all want to see it. And that pump has reduced the incidence of biliary ischemia by like over 60%, which is awesome. And anyways,
My transplant surgeons also recently showed me a video of the pump, and it was really cool.
Yeah, and like you can
In the
see
liver.
bile coming out of the
Yeah.
liver. Yeah. It's really, really neat. I mean, just technology and all the amazing things that we can do now. So anyway, so this is post-transplant liver. So what do you think?
Why there is subcapsular hyperintensity?
Oh, yeah. So we can see this sometimes there's contusion and stuff like that. Maybe sometimes there's this like ischemia that can lead to geographic signal changes on actually T2 and diffusion and post-contrast sequences. I'm showing you this case for the biliary findings. So yes.
Biliary stricture.
Yeah. So.
Or no, actually, it looks like a mismatch because if it was a stricture, the upstream would be dilated. No.
Yes. Right.
Right,
And so.
like a mismatch.
And then let me show you the T1. Here's your pre-T1. So there's probably a lot of like T1 hyper. Is that right? Let me see. I gotta put them side by side to see if there's. I think there was stuff in it, like T1 hypertense signal. And so we have a monthly DCD conference, and I was like, so when do you call it a biliary stricture versus a mismatch? And then they gave me a response that was really kind of funny, but also kind of reflects the uncertainty. They said if you ask a interventional gastroenterologist, it's a stricture. It's an anastomotic stricture. If you ask the transplant surgeon, it's a mismatch. So it's the imaging findings are the same, and it just
No, but
depends on who you ask.
that's funny, but also if it's a stricture, then upstream should be dilated, and if it's a mismatch, then it's usually like downstream that's dilated, but it's not actually having an effect upstream.
So
Because of
if
the way
we
the
start to
bile is
see
flowing.
yeah, if we start to, so then I asked, like, when do you intervene, right? So if there is imaging findings, so if there's like you said, if there's DIL, but even if there's not DIL and you see sludge, like T1 hypertense sludge build up upstream of the anastomosis, they intervene because those are early signs that there's stasis. And of course, if there's transaminitis, they intervene. So
when you say transaminitis, you mean like alk phos and bilirubin, like specifically,
yeah,
not just
yeah,
like
yes, obstructive, like if there's kind of suggestive of cholestasis.
Got it. So this case to me does not look like a stricture, but I was going on the fact that it wasn't dilated, but you're saying like if we saw sludge in that biliary tree, did you see sludge in the tree? Or I don't see here, but maybe on the
yeah,
tree.
I think I did see sludge, and I'm going to show you the ERCP images. Okay, can you see my screen? Yeah, they're very aggressive with these cases. Like, so I mean, I think I saw sludge, but it was also really narrowed, right? So even if it's not sludgy, like I recommend an ERCP. They're very aggressive with these cases because they want to preserve the liver. So this is the ERCP, and I mean, it's like there's an anastomotic stricture.
Yeah, I see it now. Wait, show me the MR again. Like, could you see that narrowing there on the MR?
1 second, let me pull up the MRCP images. And
really
sometimes like
there's no way.
Go ahead.
And I'm saying their billy must have been up because the biliary tree otherwise is not dilated. So this seems like their billy, there must have been some physiologic.
No, I don't remember. I read this study. I don't think there was elevated billy, but I told them to get ERCP based on imaging findings. There's a stricture. There's an anastomotic stricture.
That to me, like, there's so much artifact too with, like, the picture you just showed. You don't even see anything, right? Like, because there's also like structure
artifact. I think the T2 is a little bit better. How about that? Yeah.
Mm.
And sometimes, like I've noticed, the ERCP images they accentuate the findings more than we see on MR. I mean, probably because they're actively just standing it, and so you'll see it better on ERCP. So the other teaching point was, in this case it was anastomotic stricture, but the other key thing to differentiate from is confluence dominant ischemic cholangiopathy after a DCD transplant. And with those, you involve the right and left intrahepatic ducts, the proximal ducts. So it's not just the common bowel duct or common hepatic duct. You're involving the right or left as well. So you need to see those for confluent dominant ischemic cholangiopathy. And patients with kind of end stage ischemic biliary cholangiopathies, that we transplant them, we relist them for transplant. And there are 3 indications when they would go for a retransplant. The first indication is bilirubin is greater than 2. Second indication is the stricture is not amenable to stenting. Or the third final indication is if they have bacteremic episodes at least twice or more. If they meet any of those 3 criteria, then they get relisted for retransplant for biliary ischemic cholangiopathy. This is an anastomotic stricture, so it's not ischemic, but we classify these because they get surveyed pretty intensely.
Yeah, and you've shown this classification here, and it's been really helpful. My question is about when you say it involves the right and left ducts, is it like separate strictures in the right and left ducts? So
yes.
Like seeing multiple strictures? Got it. Okay.
Yeah. So if it's just like here, this is just at the anastomosis.
Yep.
But if you start to see strictures, involve the central, it needs to be, the confluent dominant is predominantly central. Central. Yeah. So you need to see at least right or left hepatic duct involvement.
Cool. Let's pretend this patient comes in for, unrelated belly pain or whatever. Patient is 80-something-year-old, older. So, and this is, routine study. So what would you guys say about this? Like, how would you report this? Like, what would you say this lesion is?
Well, there's the lesion in the left lobe, but there's also a massive IVC. And then there's like a blobby. So what phase are we kind of in? Because it's kind of a later phase.
We're in portal venous phase.
Why is the IVC so nicely opacified then?
It's a portal venous phase.
Okay.
Yeah, and then there's reflux. She has big heart, and non-functional, but routinely wrong venous phase. So how would you like? To me, this was a very scary case. I would have probably reported this hemangioma if I saw it like this. Lobulated, right? It's well defined. For the size, it's like relatively, maybe this is like just incomplete enhanced by hemangioma.
I mean, how do you know it's not? Like, I mean, it could be a shunt. I think it could also be, I don't know.
Yeah, I feel like this is not a slam dunk hemangioma because it's too filled in for the portal venous phase, and so I would say like hemangioma versus other
tribasic,
including and I would actually go for an MR.
Yeah.
So I actually, in terms of to apostrophize hemangioma, I have to respectfully. I have hemangiomas which are large hemangiomas which are fully apostrophied by portal venous phase. That can be that particular can vary.
But flash are usually
the scary part. Flash, but I have big ones that are fully apostrophied by portal venous phase. So they can be very slow feeling, very fast feeling. So I wouldn't necessarily go with like, it's too apostrophied for portal venous phase, but I would say that, okay, so this patient obviously didn't have just a routine portal venous phase. It was a full exam. So you can see it's a mass, right? Now in the arterial phase, obviously it has nothing to do, doesn't really look like hemangioma. So, once you have the full exam, obviously it's easy not to make a mistake.
I'm going to throw angiosarcoma in there.
Okay. This is her prior PET.
Wow.
Okay. So it's clearly malignant. And this is her prior MR. This is diffusion and.
Do you have the T2? Oh, there it is. Yeah. Oh, it's not as bright as I want it to be.
Yeah. So, right. So anytime we have sort of like a target-like thing, we have to think about intrahepatic cholangio and that's intrahepatic cholangio. So this is like very
robustly enhancing for cholangio.
Yeah. The intrahepatic cholangio, when they're small, I have a collection of them that if you just look at the portal venous and they're small, they look like hemangiomas, uniformly enhancing, like just perfectly matching the intensity of their vessels. And if you are not careful, you can just call them hemangiomas. But this degree and uniformity of enhancements in a big cholangio is far less common, but it can happen. So the teaching moment here for me, I think for other people maybe as well, is that, if we have only one phase and something, like I think it's safe to call hemangioma if we have like clearly, discontinuous peripheral nodule enhancement. But if we have something like this, then with this appearance, the hemangioma is still the more likely diagnosis, but you would need to prove it. You would want to follow it up. So, but in this case, this was a very tricky, intrahepatic cholangio, which it was not, this was done first, so they knew that CT was a follow-up. It was a pre, so they knew it was a biopsy. There's no errors here, but I'm just saying, like, imagine if this came in as just at the portal phase, no prior history, it's relatively easy to make an error in diagnosis and say, oh, it's just hemangioma.
Great case, great example. I've seen the small ones, the small cholangios be like super enhancing like that, but never a big one like that. So that's really interesting.
This is probably the biggest one that mimics hemangioma that I've seen.
Yeah. So there's a mass here. What do you guys think in your differential?
Paraganglioma.
Okay, good thought.
Gist.
Okay. Like it is touching the duodenum here. Last week, I think I showed you guys a case where like there was a gist coming off the duodenum like that. So that's a good thought. One thing is that like
And it's also nodes. Yeah.
yeah, there's a component.
Lymphoma?
What'd you say?
Less likely lymphoma. It's not homogeneous.
Okay, good thought. Another thought that was brought up is like, is it adrenal? Could it be an adrenal cortical carcinoma? And I just want to point out that the adrenal gland is normal right here, and actually on the coronal. You can see the adrenal gland that's like normal here. Even though it's touching the edge of it, I would say that that would be very atypical
separate.
in ACC, like to be just super exophytic like that. So anyway, but so wasn't sure what this was. And then a month went by and
Wait, they didn't get a biopsy?
Not yet, but they eventually did get a biopsy. And then you can see that it's more,
Oh my gosh.
I don't know if you guys remember exactly, but look, it's now like going into the renal sinus here, totally encasing.
Super aggressive.
Yeah. So, what are your thoughts now? Actually, I think there was
Leiomyosarcoma.
Leiomyosarcoma. Excellent thought. That's I was thinking that too. Like, could it be arising from the IVC? The IVC is over here, and on some of the better phases, it didn't really look, but a lot of leiomyosarcomas are exophytic. But I would say that this was the clue here.
Yeah, lymphoma is like going through, the vessels are going through.
Exactly. So the vessels are going through, and then now additional lymph nodes have increased in size.
Yeah, it's lymphoma.
So eventually this was biopsied and was lymphoma, diffuse large B-cell lymphoma. So it was.
See, Sean, when you say it's not, that's what it usually is in this case conference.
Yes.
I do think like this is a tricky lymphoma because there wasn't other sites, like on the original scan, there weren't other lymph nodes, right?
But
so
yeah, but lymphoma can look like anything, right?
I know. And I do like Yashant's point, they're usually more homogeneous and bland looking.
Usually,
but,
not always.
Yeah. In fact, you mentioned it is DLBCL, so that's one of the more aggressive types. So aggressive lymphomas can be heterogeneous.
Yep. And yeah, exactly. It grew in a month, and so still was weird for lymphoma, and maybe that's why it's so heterogeneous. Exactly. But encasing vessels, so very good for a lymphoma. So yeah, we were all thinking down like the sarcoma, and some people were thinking ACC, but this was lymphoma.
I have a quick one.
Okay.
So abdominal pain, and we see this incidentally.
Is it external to the patient?
Yes. Is it like wait, hold on, some kind of
device? Like a phone, but it's not a phone, it's like a charger and a.
That's a very good thought.
Yeah, like a charger and an iPad.
That's a very good thought. That's the hint, actually.
A very good thought.
And do you see at the periphery of the image something?
A lock?
Exactly.
Oh, wait, are they in prison? Wait.
Correct.
And these are shackles? Wait, what?
Stun vest.
What?
Like how we have stun gun, like electricity, so that the prisoner does not run away. So this is like a stun vest.
Oh, that sounds awful.
Oh, wow. So stun them if they try to run away.
Yeah. So instead of how we are used to seeing those like big shackles and the chains around the waist, so this is a different alternative.
So is it on their waist, like on their torso, or?
Yes. Yeah.
Oh, wow.
I mean, I did not find radiology images, but I can show you how it looks. Give me 1 second. So that's how they look.
Wait, but is it for self-defense or it's for stunning somebody else?
It's for stunning. Sorry about that.
Oh, interesting. It's okay. I think we get the idea.
Sorry about that.
So anyway, basically, once you've taken somebody into captivity, you can put the stun vest on them and then activate it if they start running away.
Yeah.
Interesting. Thank you.
Actually, can you unrecord for a sec? So this is a patient who's presenting with lower GI bleed and low hemoglobin. So we got a GI bleed protocol. So there's lots happening here. And
Are you scrolling? Because I only see a static coronal image.
oh shoot. Okay, is this better?
Yes, I know.
Okay.
It's scrolling.
Okay. So there's a lot happening here, and I'm gonna ask you to just focus on the colon.
I see like a necrotic mass in the sigmoid.
Where? Where? Here?
There in the center of the image.
Good. Okay, great.
And then
Okay.
it's like growing beyond it, like into that
Uh-huh.
nodule. Yeah. What is that? Oh,
That-
that's uterus?
Yeah, that's uterus.
It's like
Okay.
invading the uterus.
Uh-huh.
Rising from the uterus.
Good. Keep going.
And
There
then
is this transverse colon mass.
Yes, yes. So this turned out to be synchronous adenocarcinoma involving both the transverse colon and the sigmoid. So, run the colon. Even if you found one, keep going because there could be more than one. So this was both, colon cancer. So.
what was the sigmoid one mucinous by chance, or just like why is it so low density?
Oh, well, they were adenocarcinoma. I don't know if they were mucinous or not.
And was it involving or invading the uterus? Or that was
I don't think it was invading the uterus on the surgical specimen.
Okay.
And I'll get back to you about mucinous.
Okay. Okay, so this patient came with right upper quadrant pain. This is an ultrasound. Anything stick out to you guys?
Biliary dilation what was that? Biliary dilation or yeah.
Yeah, exactly. So I just wanted to show this is a nice example. Like, so we see our portal vein, and usually our common bile duct is really small. And then intrahepatic bile duct dilation can be tricky, but when you see this many tubular structures, this is too much, right? So some of these are portal veins, and it would have been good if we put color on here now, but some of them would not opacify and were actually dilated bile ducts. So we've got like two sets of tubular structures next to each other. So one portal vein and one's a dilated bile duct. So this was Bildil, and then they got a CT. We see the Bildil better here. And we can see that there's a stent in place that's a little bit low lying. So it's going into the third portion of the duodenum. See anything else?
The fat plane with the IVC and duodenum is not clean. What's there?
There's like a mass in the lower CBD.
Good, 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 good. So here we can see that there's actually like a filling defect here in the CBD, which I think can be tricky on CT, but that's what was causing the buildup. So it wasn't just because the stent was displaced inferiorly, but there's actually something in there. And then the question is it a mass? What is this ball here? And it looks like an enhancing kind of mass, right? Like, is that an intrahepatic cholangio? What is that?
It could be papilloma. It could be, yeah.
Yeah. So we got an MR and they're just stones.
Oh, wow.
Wow.
Yeah. So it just shows you how much nicer we see stones on MR. Sometimes we really don't see them on the CT. They're often not calcified, so they're not hyper dense. And then here we can see they're just really dark stones. So just a couple of pitfalls, like ultrasound, sometimes hard to see the buildup, CT, sometimes hard to see the CBD stone. So MRI can answer a lot of these questions. Yep, that was it. Okay.
I'm going to trick you first with this forearm ultrasound. So those are the muscles, and we see these few nodules. So any thoughts what's going on? And that's not just one, there are multiple.
This is where I punt to MSK. I guess our MSK people do joint ultrasounds. And we do soft tissue, but I'm not.
Okay, I mean, it's difficult, like if I just showed you the forearm thing, but let me show you what happened at least 7-8 years ago. So that's the ultrasound of the neck.
Oh, is it parathyroids that they relocated to the arm?
Absolutely. And the patient is a known case of Meneman syndrome. 3.5 parathyroidectomy was done, and the half parathyroid was put in the forearm. And then a couple of years later, those became adenomas. They started hypersecreting. The patient started getting symptomatic again, and those are the stones. And then they did a ultrasound followed by nuke med scan, and it was positive. So they had to re-explore the forearm and take all those pieces out.
Wow. Really interesting. It must have been hard to find them.
Yeah.
That's why they did your ultrasound.
Yeah.
To see. Wow. Cool.
And interestingly, like I was waiting for this case for such a long time, and then I saw 2 in a row.
Oh, wow. They always come in pairs.
Yeah.
Okay.